My presentation is a reflection on training of healthcare professionals to handle difficult situations. I have been working at medical faculty for more than 20 years, but I have never been involved in study program development. Partially, it's understandable, as I'm just a psychologist and scientist, not a medical doctor. However, we participated in 2 Erasmus Plus projects, first one with acronym SHANS, aim, develop and implement curriculum on migrant health study program. The second one, with acronym IMPACT, aim to develop and implement a set of learning units to build professionals' capacity concerning health literacy in medical and nursing education. In both cases, the focus was not on clinical competencies, but rather on competencies to work with vulnerable groups, and in both cases, we failed in implementation phase. As psychologists in medical environment, we are allowed to develop and propose an elective courses, and after tough and exhausting negotiations, we are allowed to offer it to students, but mostly we couldn't guarantee that there will be a space for students to follow it, even they will be interested in it. So I have vast personal experiences with Don Quixote route, heading to implement change in medical education and training. From local level to national level, up to international level, it's very resistant to any change. I would not call myself Don Quixote if a gave up would be an option. I saw amazing, inspiring cases of good practice around, and as a person I deeply feel duty to fight for better training, as it means better care, dignity, safety for any of us and our close relatives in very vulnerable situation of illness. Take my presentation as Don Quixote reflection on selected challenges. The first challenge is a combat zone. You train them for certain combat zone. You train them to survive, even more to thrive, while providing excellent health care, assuring also patient safety. And one day, you will send them out to the combat zone. Pandemic emphasizes strengths and limitations of our healthcare system, including medical education and training. It's nearly impossible to avoid handling difficult situations while pandemic is ongoing. It's so massive that no weakness or strength could be hidden. Therefore, I will use the context to describe mental health challenges of healthcare workers. Difficult situations happen in certain cultural, legislative and societal contexts. Mental health challenges arise from work conditions, work characteristics, and the way how the situation is experienced by healthcare workers, and there are institutional and individual resources to handle it. With regard to pandemic, it was biological risk related to working environment, limited knowledge and training for this kind of the work, limited access to personal protective equipment, fluctuation and lack of staff, overload, and so on. The management of patient was demanding due to emotional response of patient and their relatives, and particularly due to the lack of the training to handle it and insufficient or lacking support, necessary triage and related ethical dilemmas, particularly when it was officially denied, demanding care, dramatic changes in patients' health and too many deaths that was not common for them, more frequent patient safety incidents, adverse events. More than the fear of being infected, first-time healthcare workers were worried about infecting their loved ones, but some of them experienced fear and even panic reaction, and many experienced stigmatization of them or their loved ones due to their profession. Information overload, ambiguity, uncertainty, and mainly the fact that they have to follow news as it's defined their next day life was very demanding. Healthcare professionals experienced helplessness, dissatisfaction, irritability when they witness irresponsible behavior of the public or patients, but also due to mistakes of medical staff resulting from fatigue, stress, or insufficient conditions for work. They experience moral distress associated with helplessness, dissatisfactions, feelings of guilt, when they perceive the fears of patients who had to be left unaccompanied, in some cases to die isolated, which was not in line with their belief in good care. Some tend to downplay symptoms, dissimulate, overestimate their own capacity to respond to an emergency and be fully available. And the most common experiences are exhaustion, lack of sleep, and depression. For many of them, it was not boring routine work, but an extremely difficult situation lasting several months, and the emotional, psychosocial, and behavioral response lead them to one of 3 trajectories: thriving, surviving, or dropping out. This is our battle zone in worst case situation. Thriving of healthcare workers confronted with difficult situation is an outcome of these complex situations having roots in a history. Cultural, legislative, and societal contexts define medical education and training, define healthcare infrastructure, work conditions, patient management, societal expectations, healthcare worker expectations. So the same situation of pandemic result in a different range and intensity of mental health challenges and different scope and availability of resources. Training without fixing toxic elements in an environment might not work as a shield, but as a shooting target and might cause harm and resilience erosion. Imagine that you will train medical students in speaking up or disclosure of adverse events while not fixing cultural, legislative, and societal context. It might mean that you train a kamikaze pilots. It will just not just harm a student, it will massively discourage anybody to follow it. You might develop the competence for mindful and reflective approach to practice, but if not fixing work conditions and patient management, you just open more space for moral distress and moral injury, knowing that there is no help in place. Instead of making them more resilient, more safe, you will make them more vulnerable, more at risk. If this should not happen, we should keep eye on battle zone, not just for identifying what we need to train, but also for what we need to fix to increase their survival chances. Our trainees should come back home alive. As a second challenge, I pick a framework of core medical competencies. If it's implemented in study program and clearly connected to activities and expected outcome assessment, it's very easy to work with it. I'm pretty sure that many of you are familiar with CANMEDS. This framework identifies and describes the abilities physicians require to effectively meet the healthcare needs of the people they serve. These abilities are grouped thematically under the role of professional, communicator, collaborator, leader, health advocate, scholar, and professionals, and integrating role of medical expert. So we expect that a competent physician is capable to integrate all of the CANMEDS roles, applying medical knowledge, clinical skills, and professional values in their provision on high quality and safe patient-centered care. Taking into account that each of competencies contribute to high quality, efficient and safe health care, what undoubtedly has the roots in resilience and contribute to resilience, or vice versa, has the root in limited resilience and contribute to erosion of resilience, there is one role specifically focused on resilience, and it's the role of professional. Within the role of professional, we expect that physicians are able to demonstrate a commitment to patients by applying best practice and adhering to high ethical standards, a commitment to society by recognizing and responding to societal expectations in healthcare, a commitment to the profession by adhering to standards and participating in physician-led regulation, and a commitment to physician, health and well-being to foster optimal patient care. And within this competence, it means taking care for their own health and well-being and that of their colleague. Key concepts of commitment to self includes applied capacity for self-regulation, commitment to disclosure of harmful patient safety incidents, mindful and reflective approach to practice, resilience for sustainable practice, and responsible to self, including personal care in order to serve others. So within this competence package, we expect that physician is able to exhibit self-awareness and manage influences on personal well-being and professional performance, manage personal and professional demands for a sustainable practice through the physician life cycle, promote a culture that recognizes, supports, and responds effectively to colleagues in need. Concluding, we have an excellent tool listing our target, but the question is if and how it's implemented in medical education training. I have two personal experiences, both from home universities, as I work parallelly for two medical faculties, one in Slovakia and one in the Netherlands. Study program in Groningen is based on CANMEDS, and it's a problem-based program which is patient and student-centered. Already on a bachelor level, it consists of three kinds of units of study. Causes of disease focus on the development of medical knowledge. Competence development focuses on the development of competencies important for being a good doctor. And the last one, knowledge development, aimed to assess individual progress and recognize the gaps in medical knowledge. Within this study program, it's very easy to identify target competencies as well as training activities and to assess it. And in case of need, focus on it, change it, or improve it. On the other hand, medical education in Košice is rather traditional one, emphasizing passive methods, strict division on disciplines, where students acquire specialized knowledge in theoretical, preclinical, and clinical subjects through lectures, seminar clerkships, specialized practice, and consultations. I did my best, but I couldn't find any theoretical model or framework of competencies. I tried to read carefully all accessible documentation at our faculty as well as on national level, and you have to read carefully to find the core physician competencies drowned in documentation rather as a byproduct than as a core issue of education. One small example is a graduate's profile where term personality is used and it's in a sentence including also foreign language and it's referring to Hippocratic Oath. And this is the main problem. I'm very much afraid that many medical students and professionals intuitively include these core competencies into their equipment and are developing it, perceiving it as something out of their role, something additional instead of core. And yes, we might expect, and study guarantors will definitely assure us that all core competencies are in, but it's very difficult to identify what activity is focused to train it and what to assess it. And because it's drowned in and fragmented in many subjects rather than like byproduct, there is hard to find an entry point to put effort together to connect each other in this effort. We could just rely that it will happen somehow. The last challenge I plan to mention in my reflection is a learning environment. Each year there are more than 100 research papers published in Web of Science if you will use keyword learning environment and medical education. Apparently it's not just what we thought, but also where we thought it, what is around or surrounds. Both psychosocial as well as material dimensions matter. Useful tool is a conceptual model from Gruppen et al. There are several assessment tools like Dream, Clay, Helmlen, focusing rather on psychosocial dimensions. Gruppen published also a scoping review on interventions designed to improve learning environment. And again, most of interventions were focused on psychosocial dimension. And I would point out, referring to Bandini et al., the crucial role of hidden curriculum, which students are not taught but have to pick up through socialization process at clinical basis. It seems to be that imprinting is applied mainly when students enter clinical basis and interact with tutorial teachers, clinicians. Therefore, I tried to look at evaluation of university hospitals in my country to see how core role model clinical bases look like. I pick up evaluation of hospitals in Slovakia for period 2016 and 2019, so I try to avoid pandemic period. There are university and state hospitals on the left side and other hospitals on the right side. The greener, the better. I know that letters are too small to read it. I pick up one of 3 main university hospitals and compare it scores with other 33 non-university hospitals. As you might see, this hospital, university hospital, scores very well in experience, quite well in transparency, but for the quality, patient satisfactions, economy, or general evaluation, it scores very poorly. This hospital is on the tail of the rating. It's true that medical faculties try to use clinical basis out of the university hospital, and let's believe those better one, but it seems to be that university hospitals hardly could serve as model environment worthy to copy. And it might be that most important part of imprinting is happening at this on the tail of rating clinical basis. Thank you for your attention.